This is the Psychedelic Medicine Podcast.
Hello and welcome to the next episode of the Psychedelic Medicine Podcast. I'm Dr. Lynn-Marie Morsky, your guide on this journey, and today we're going to be discussing ketamine-assisted psychotherapy for chronic pain with Dr. Michelle Weiner. Dr. Weiner is double board certified in Interventional Pain Medicine and Physical Medicine and Rehabilitation, and she is the Director of Integrative Pain Management at Spine and Wellness Centers of America. She uses a unique, personalized approach to treat the root cause of pain using a biopsychosocial model, including lifestyle implant medicine, to empower her patients to cultivate health, optimize quality of life, and decrease pharmaceuticals. Now, before we get to our discussion with Dr. Weiner, just a reminder that the Psychedelic Medicine Podcast is for educational and informational purposes only. Nothing here is to be construed as medical or legal advice. And as always, if you, like Dr. Weiner, are a clinician of any sort, doctor, PA, therapist, nurse practitioner, and you'd like to learn more about psychedelics, please check out the Psychedelic Medicine Association. It is our mission to make sure that you are well equipped to speak with your patients about psychedelics and refer them to psychedelic therapists when appropriate. And our website can be found at psychedelicmedicineassociation.org. Now, without further ado, thanks for joining us today, Michelle.
Thank you for having me. I have so much respect for you and for the PMA because I have learned so much from your podcast. So thanks for having me on.
Oh, thank you so much. You are making my day. And you have been kind enough to come on to one of the Psychedelic Medicine Association webinars and share your knowledge with us. So I really appreciate that. And we're going to expand on some of that knowledge today because you address something that I don't think we have addressed. And again, we've done 135 episodes, so forgive me if I'm wrong, but I don't think we have really thoroughly addressed, especially ketamine for chronic pain yet. And so I'm really excited to have this discussion. Can you tell me a little bit about your pain, your chronic pain practice and the patients you see and the different ways that you have used, I guess, namely ketamine at this point to help them?
Sure. So I am an interventional pain management physician. And about 6 years ago or so, cannabis became legal in Florida. And so because of that, I started to use cannabis as a substitute for opioids. And I did some research looking also at using cannabis for seniors. And I realized that I'm a pain doctor, and all I was doing was prescribing medications and doing injections. And so I was very frustrated. And so plant medicine and cannabis really opened my eyes to a different way of treating the whole person. And because of that, I learned how to personalize different routes of administration and to have a little bit more of a relationship with my patient. And the patients that I was getting for cannabis were fibromyalgia or chronic pain states that were no longer able to be treated with interventions. And I was very curious why some people who have acute pain, the pain doesn't stop and why it turns into chronic pain. And so that became a fascination of mine. And so I stopped doing as much interventions and I started focusing on the chronic pain population and less on the acute. And I realized that a lot of the chronic pain patients I was seeing also had other comorbidities. Perhaps they had PTSD or depression, Lyme disease, other type of viral infections, IBS, chronic migraines, and there was always a story with them. There was, when was the last time you remember you haven't had pain? 15 years ago after this trauma that then, spiraled into someone in my family was sick and I was a caregiver. And so there was always a story. And I wondered, in this population, of course, we're not treating them well because we're not paying attention to the psychological and the social aspects of their chronic pain. And I was trained in ketamine in my fellowship through anesthesia at University of Miami. But when we did ketamine infusions back then, we would do them Monday through Friday for 4 hours at a time with benzos in using IV. And so as I was using cannabis for patients and helping them treat their pain, and then they realized, they were sleeping better, their depression was better, I also realized that it had the ability to alter their consciousness. And that side effect from cannabis allowed me to realize that with ketamine, I was taking away the potential for dissociation and the psychological insight by using benzos the way that a lot of the anesthesiologists do. So I started learning a little bit more from my psychiatrist friends and psychologists about incorporating therapy into ketamine. And that really changed the way, obviously, that I use ketamine now. I started to understand the difference between psychedelic versus psycholytic doses. And so the fascination first started with the concept of incorporating therapy, integration, and the fact that preparation was probably the most important aspect, whether a person is going to have a good session or not. And by good, I just mean whether they were going to feel safe enough to let go into the experience. And so I realized that I had to incorporate therapy. And so I paired up with an amazing integrative mental health clinician in South Florida, Sherry Kaplan. And we started to think about this population. And I talk a lot about central sensitization. So, central sensitization is a process where the central nervous system is hypersensitive. And usually that happens when people have had past trauma or some type of immune issue that creates this wind up phenomenon in the central nervous system. So most of the time, when people have peripheral pain generators, like you fracture your toe, for example, we're able to decrease that pain quickly. If not, the neurons become sensitized over time and the pain can spread up into the central nervous system, creating this wind up phenomenon. And so I was more fascinated with the population that had central sensitization, where there wasn't really a peripheral generator that I could treat, but it was more now a process in their central nervous system. And what we were doing was trying to teach them tools to get out of fight or flight. And so I realized that a lot of their pain is really similar to fear and fear in the brain. And so I related the fact that if we're not able to understand where this fear is coming from, we're not able to extinguish their pain. So I really changed the way I practice and use ketamine because I started to think more about how the psychiatrists are using it in terms of preparation and integration. And that was kind of the concept behind why we started to do the study on chronic pain in more of a psych context.
Yeah, and thank you for that background. And there's so many things in there that I'd love to pull out. One, just so that the listeners can know, I know we've discussed this in previous episodes, but I love coming back to it. If you could explain the difference between psychedelic and psycholytic doses. I know we don't use those words too much in kind of the common vernacular, but in case anybody happens to be reading the, or a psychedelic journal report or something, very often those terms are used. Can you clarify what the difference is between the two?
Right. So psycholytic, we think more of like a lubricant. We give them a low dose and we have them talk during therapy, talk during the ketamine session. So we can either give them a low dose and have therapy right after, or even during therapy, during the ketamine session. But the point is really to open them up, making them more comfortable. Someone may have had a trauma that they don't feel that they're able to express themselves. If we give them a low dose, perhaps they're able to speak more about that trauma. Psychedelic dose is really where we're giving them a dose that they're having a psychedelic experience. So we're changing their level of consciousness. If it's, in terms of ketamine isn't exactly a psychedelic, it's a dissociative anesthetic. So to me, that would mean a dissociative experience, could be with ego dissolution or not. In terms of psychedelics in general, it's going to be a higher dose that allows them to change their ordinary state of consciousness. And then
Understood.
usually therapy would be a day or two later.
Yeah, I guess that is something that I'm glad you pointed out, because we always talk about ketamine-assisted psychotherapy kind of like this monolithic thing. But as you point out, there are different varieties. Like
Right.
both
And
of
that
those would still fall under that.
right. So the idea behind the study was actually to group chronic pain and patients with depression into a psychedelic versus psycholytic, meaning we'll microdose you with a 25 milligram or 50 milligram lozenge and have therapy during the ketamine session, or we'll give you an intramuscular dose, usually 2 doses, and then have therapy a day or two later.
Understood. And since you brought it up, we are going to get into your study. If you could talk a little bit about what led you to want to study not only chronic pain, but chronic pain, and those who have, as we would say in medicine, comorbid, but who also have depression?
Right. So initially, I was very attracted to the fibromyalgia population. And I wanted to do a study specifically looking at using ketamine for fibromyalgia. Most of the ketamine research in the pain literature is on complex regional pain syndrome, which is a hypersympathetic nervous system response to a peripheral injury. So an extremity gets injured and it creates this cascade, and there's a lot of pain at the site, but the pain can actually spread into that limb and other limbs as well. And so there's moderate evidence for using IV ketamine for complex regional pain syndrome. In terms of the other evidence, it's always chronic pain with a comorbid depression, PTSD, or anxiety. Otherwise, there's very limited evidence. So I wanted to specifically look at fibromyalgia, but I didn't want to use IV infusions because I wanted to make it more comfortable for the patient. I wanted to personalize it, make it more relational. And I also felt like if I had a patient with fibromyalgia and you have a patient with depression and they're the same patient, would we treat that patient different because of their condition as opposed to treating the whole person, right? So someone may have a chronic pain condition or a mental health condition, but whoever is the clinician treating them may have a different approach. So I wanted to see if there's an ideal route of administration, if it's dose dependent, and so that's why we picked intramuscular over IV. But in general, with fibromyalgia, it's more of a central sensitization, or what we call nociplastic pain. And nociplastic pain is a newer term in the pain field. We usually talk about pain that could be neuropathic, related specifically to the nerve, or nociceptive, which is more of a musculoskeletal or osteoarthritis type of pain. So nociplastic means there's no real biomarkers, there's no physical tissue damage. And that's very common in fibromyalgia. And so knowing that it's a central process, I thought we could use ketamine because in central sensitization, we have this upregulation of the NMDA receptors in the spinal cord, as well as different parts of the brain. So I figured if we can use a certain amount of ketamine, perhaps we can block this receptor and start the reverse of the cascade and decrease central sensitization. And I decided not to just study fibromyalgia because I realized I would be excluding men, first of all, because there's a very small amount of people who have a very small amount of men who have fibromyalgia. And also I was just interested to see chronic pain as opposed to specifying it by type. If it's diabetic peripheral neuropathy, if it's trigeminal neuralgia, there's many different chronic pain states. But what I was really trying to understand was, now that it's in the central nervous system, does it really matter what the pain generator is if it's now in the brain, basically? So that's why we decided to use chronic pain with depression.
Thank you for that. And I love how thoughtful your study design was, because absolutely, I think fibromyalgia, there are so many people out there who realize that's so difficult to treat. So I imagine that would have been definitely a pull to want to study that. But the fact that it would exclude men is real. So I appreciate that you made that alteration so that we could find out if this works kind of across men and women. Tell us a little bit about how this study was designed. Like you said, there were the psycholytic and the psychedelic. Was there also a placebo?
Yeah, so there was no placebo. It wasn't randomized. It was really a study to just um, to start the pain world thinking about using therapy. Honestly, that's really how it came about. So what we did was we got funding from one patient of mine who has significant benefits from ketamine, actually. So it wasn't really a very funded study. We did it on the weekends, and so what happened was we would do a ketamine session, intramuscular ketamine session with therapy following. We had 6 sessions of that in the psychedelic group. In the psycholytic group, we had 6 sessions of microdosing ketamine that went anywhere from 25 milligrams up to max of 75 milligrams over 6 sessions. And there was all different therapy also involved: EMDR, IFS. We do pain reprocessing therapy. So different types of therapy techniques. But what we ended up finding out with a lot of the chronic pain depressed patients was that the underlying issue was chronic stress or unhealed trauma. And even if they did have a real peripheral pain generator that we were trying to already take care of, now that it had spread into their central nervous system, their body misinterprets these signals as threats or as pain, and they weren't really able to decrease that. Also, they were hyper focused on their pain, and it became a part of their identity. And so, by actually taking them out of this default mode, essentially, we were able to detach them from that concept and really try to allow them to learn a new way of living, and to allow them to say, instead of saying, I can't, it would be more, how do we move forward? How do we have a pacing protocol to help them start to move a little bit more, give them tools to help them with some resilience to stress, and just give them a new opportunity. And what we realized was the group that had the psychedelic dose significantly improved much more than the psycholytic dose. So the concept really was, if higher doses of ketamine are more effective for chronic pain and depression, then at least we know we can still use the intramuscular route. And that's the other thing. A lot of the pain doctors are mainly doing IV infusions, not paying attention to preparation or integration. And I wanted to just give them the option to say, why not try intramuscular and have more of an involvement, be more involved in the actual session, as opposed to just, here's an IV, and sit in this room for 4 hours and not pay attention to mindset and setting. And so it's kind of like a combination of psych and pain, merging together.
And when you so to clarify, if they're doing the intramuscular, is there because I know you said that with a psychedelic dose, the therapy is still after, but is the therapist hanging out? Like you said, instead of just, leaving them with an infusion, the intramuscular is different. Can you tell us what that looks like, even though they're in, an altered state of consciousness?
Right. So the psychedelic dose would be, usually we would start, zero point 0.7 milligrams per kilogram. Zero point 0.5 I've noticed to be pretty low for the pain population, and then we would increase that dose each session, or we would find the dose that best fits them. We The environment is a therapist's office, so it's set up, properly with the recliner, and decorated beautifully, and essential oils, and we have obviously music and playlists for everybody, and eye shades. So as opposed to when I was in my fellowship, we would be in, the PACU, or with all the other patients who are having surgical procedures and not paying attention to setting at all. So it was done, the way that I think ketamine should be administered. And then the therapist and myself were there the entire time throughout the session, in case they wanted to talk, in case they had something that came up, we would write it down. So there was much more involvement. And actually, I really like not just putting a patient in the room by themselves. I feel like a lot of times the concept of being with others, and even group ketamine assisted psychotherapy, can be very helpful, because they feel safe, they feel supported, they know that if they need something, they have someone there for them. So I think that it's really very important, the preparation that goes into these sessions.
Absolutely. And you said that there was more improvement in the psychedelic group. Was there still improvement in the psycholytic group?
Yeah, so there was improvement, and everyone actually did get better in all aspects. So we looked at mystical experience questionnaire, Beck depression, brief pain inventory, generalized anxiety disorder, and PTSD checklist, the PCL-5. And so in all of them, everybody did improve. However, the improvement was larger in the psychedelic dose.
And how long afterward, like, was the follow-up? Do we know how long those, when was, I guess, the last time point that was checked to see if they were
Yeah,
still experiencing?
we did baseline. We did after the first session, after the third session, after the sixth, and then 3 months. And I think that's the biggest problem currently with ketamine for chronic pain, and even for mental health, is that there's not a lot of longitudinal evidence showing how symptoms improve or remission happens even, post 6 months. Everybody knows that ketamine is a rapid antidepressant, and for acute pain, it's really wonderful, but the chronicity is the issue. And I think that what I've seen is that ketamine does require maintenance, in the sense that even if we do 6 sessions, a lot of patients do need to come back after a few weeks or a few months for maintenance treatment with ketamine as well as therapy.
Okay, and that's thanks for clarifying that. I was so curious about this thing that you brought up about the identity piece. At least when I was still practicing, I saw a lot of that with patients that had chronic pain or something chronic like Lyme disease.
Mm.
And this is, and just to clarify on the outset, this is not a judgment of making this your identity. It just is what happens a lot of time when so much of your life has to be molded around these limitations that this condition has conferred upon a person. Did you see anybody able to shift their identity through
Yeah.
this?
Well, I think the biggest issue is that we have such poor pain education in America. So our physicians aren't properly educated about pain. So then the patients, who are they going to get their education from? And so when a patient has chronic pain, if the physician is trying to explain to the patient why their acute pain turned into chronic pain, or why they all of a sudden have generalized full body pain, if they can't explain it to them, then the patient doesn't understand how to even reverse this or how to treat it. And so, because the education, I think, is so poor, it feeds this problem of a patient who has pain staying stuck to this identity because they feel there's no way out. They feel that this has become who they are. And what's interesting is that with fibromyalgia, there's been functional MRI studies showing how there's dysregulation in the default mode network and in the insula. So basically, the part that has our autobiographical story of who we are and how we judge pain are dysregulated, which is interesting because usually we say fibromyalgia has no objective findings. However, there are some things that are coming out now. There's even inflammatory mediators in the CSF of fibromyalgia patients. So there's much more to the picture than just the psychosomatic concept that we've had for so long, but there's this concept of neuroinflammation. So I think what happens with patients is who have chronic pain is they lose hope, and they start to learn behaviors that keep them isolated and that keep them, stuck in a mindset that they are not able to break free from. And so it becomes who they are. And so by allowing them to either alter their level of consciousness or have the opportunity to basically have a timeout, to say, I'm going to take a space now to get out of my mind and get out of my body that's physically hurting me, or that this voice in my head that is continuously telling me that I have pain and I can't do certain things. Just that timeout alone allows them the space to say, oh, maybe I can do this, or I did feel no pain for a 2 hour period, or I did feel love or peace in something that I haven't felt before. And they start to understand that the feelings that they're missing in life, once they feel it, they realize, oh, I can access that. I can feel that again. And then they start to have hope. And I think that because pain education is so poor, patients lose hope. They think, I have fibromyalgia, I'm going to have this forever. I have chronic pain, I'm going to be on these medications forever. There's no way out, there's no other options. And I think that feeds into this cycle of fear and pain that is just continuous, and doesn't allow them to move forward in their life.
Yeah, that makes total sense. And you talked about the two things that were often at the core being chronic stress and unhealed trauma. Did that I mean, how did you elucidate those two things? Was it through the therapeutic sessions that those two came out?
Right. I think that also physicians don't take a good history. They want to know what's going on right now, but they are not looking at the whole picture, the big picture. So I think when someone's sense of self has become, pain or fear, they really can't see anything different than that. And so when I try to talk to someone who doesn't really have a reason to have pain in the sense of their physical body, there was no peripheral damage, then you're wondering, okay, well, how did this cascade happen? And usually, if you ask them back to what happened during their childhood, or when was a time that they remembered they didn't have pain, when did that change, then we are able to get a better history, which is how we treat chronic pain using a biopsychosocial model, meaning who is supporting you in your life or who has not supported you. What are your coping skills? Not just what's going on in your actual tissue, but like, what are your thoughts? What are your beliefs? All of these things were addressed with all of these patients. So most of them had had some type of trauma in the past or some type of chronic stress, whether it was stressful emotional things or it was physiological changes in their nervous system that never was really dealt with. And I think that's a big issue that we have right now is we have a neuroinflammation issue. We have problems with inflammation in our body that we're not really able to treat properly. And I also think that trauma creates chronic stress that affects how our brain and our body are communicating. And I think the functional connectivity is really what's important here. So when I started learning more about neuroplasticity, because as much as I knew about ketamine and glutamate from a pain perspective, I realized that neuroplasticity is stimulating the connections. And what was happening with fibromyalgia and chronic pain was that it was neuroplasticity gone wrong, right? It was the fact that they were in this central nervous system that felt like they were misinterpreting these signals. They couldn't decrease the pain. They had this wind up, and the plasticity is in the spine and in the central nervous system. And in order to quiet that down, we needed more than just a pharmaceutical, right? That wasn't going to happen. So that's why when the patient is able to realize we have this therapeutic alliance, myself, the therapist, we're able to discuss with them their past trauma, then we're able to dissect it a little bit better and understand, and then they could understand why this has happened to them, and they could start to take some ownership and then say, okay, in order for me to get better, there's not going to be a medicine that's going to cure me. I'm going to have to actively participate in my own health care. And I think that so many people are just passively waiting for the next medication to fix whatever has gone wrong, as opposed to realize that nutrition, exercise, our lifestyle has such a big part of that, but also understanding past trauma and also trying to decrease stress will decrease overall chronic pain.
Yeah, absolutely. And that is a really important point. And I'm glad that through that therapeutic alliance, you were able to help people find that. I was wondering about, speaking of the therapy, you had mentioned that EMDR was used, IFS, which is internal family systems, and then pain reprocessing. Can you tell me a little bit about what that is? I've never heard of that.
So I read a book by Alan Gordon called The Way Out. And it was very interesting because what he did was he took people who had MRI findings of in their lumbar spine of either disc herniations, disc degeneration, stenosis. They had physical pain symptoms in their back, and he did an 8-week course of pain reprocessing therapy. And at the end of the 8 weeks, 0 of them had pain. So it's an interesting concept because maybe you don't have pain. I do an MRI of your back and I find something, right? And maybe you do have pain and I do an MRI of your back, I find something, but that may not be the source of your pain. So what he did was something called somatic tracking, which is kind of similar in EMDR, because what we do is we have the person figure out where is the pain. So track your body, where's the pain, and then we do a meditation or a breath work to help calm the pain down, and then show them how they can do this themselves. And then we pay attention to the voice in their head that tells them not to go out or not to do the, not to get out of bed, and to actually start to reprocess where this pain is really coming from, and to understand when you ask someone what makes your pain worse and they say stress, then you're thinking, okay, yes, pain is in the brain. I do understand that. So stress could make it worse, but also, what are you afraid of? You're afraid of having more pain, or where is this really coming from? So the somatic tracking is very important so that they can really understand what makes their pain worse, what makes it better, how to calm down their pain. And it's really using mindfulness techniques to treat their physical pain. And and it's just amazing to think how we are treating people based on imaging as opposed to really understanding the source of their pain. Because a lot of chronic pain patients that I have over time, once they start to understand that they need to take a little bit more of responsibility for their everyday life, because they get very stuck in the I can't exercise, I have too much pain, right? Or the isolation because they don't want to be around other people because they have pain. And all of these aspects are actually creating more stress, that's creating more inflammation, that's exacerbating their pain.
Yeah, absolutely. Um, I well, first off, I'm totally like off topic, but I would love to know in your practice, you've worked with ketamine and you've also worked with cannabis. Is there a way when a patient comes to you that you decide which would be more ideal to address their issues?
Yeah, so that's a great question. So I have a lot of what I call endocannabinoid deficiency patients, fibromyalgia, chronic migraines, pelvic pain, that kind of thing. And so my concept is really cannabis can be more of a daily medication. Ketamine is going to be something that you come to the office for and you do 4 to 6 treatments in a very short period of time, and then probably require some type of maintenance a month later or a few months later. Cannabis to me is personalized in the sense that they may choose something for the day that may be different for at night. But cannabis is a great plant that can allow the person to take ownership of their own health, so that they're understanding how does cannabis affect me in terms of my mental state, in terms of my physical state, what dose can I take, what route of administration, how much CBD do I need to negate the intoxicating effects of THC. So usually if I'm doing ketamine for a person, they're probably also on medical marijuana. And that is because I'm trying to make sure they're sleeping well, which is always my number one thing for all chronic pain patients, is really trying to get a good night's sleep. And then I'm trying to improve their mood and treat their pain during the day. So usually I'm doing both with them. It's not one or the other. I usually don't have them use cannabis before their ketamine, but after ketamine, they're able to use cannabis.
Okay, great. Thank you for that explanation. Is there anything that I haven't asked about the study or about how you practice with your patients in ketamine that you'd like to share before we wrap up?
What didn't I include? Well, I'll say that, this was a pilot study. It did have a small sample size, and my goal would really be to try to do more work using intramuscular ketamine-assisted psychotherapy for chronic pain. So that was really, the concept is, do we have to do infusions, and can the pain doctors be a little bit more aware of the setting and preparation and integration, so that we don't need to use benzos, and we can actually have this dissociative experience to allow them to have hope, or to, really to get out of that fight or flight. Um, and that's, I really look forward to longitudinal studies, because that's really what we're missing now. It's very sad because a lot of the information that we have is based on self-pay patients, which already is a bias there, right? So if we're able to have this medication FDA approved, which we do, but for chronic pain, not obviously in an intranasal form, then I think we're able to have better outcomes. And I think that's really what we need to be looking at now, is what's the best protocol, and in terms of intervals in between. But why not incorporate integration and therapy when you're treating chronic pain?
Yeah, absolutely. Well, I appreciate you bringing that to the forefront and your continued work to educate others on that aspect, and all of your work in the field, period, and with all of your patients. We were going to put a link to your study in the show notes if anybody wants to check it out. By the way, show notes can now be found at both plantmedicine.org and psychedelic medicine association.org. Click on podcasts. Michelle, can you tell people where to find more about you and your clinic and your work?
Sure. So my practice is in South Florida. I have offices in Boca, Hollandale, and Miami. And my website's drmichelleweiner.com, and my Instagram is Dr. Michelle Weiner.
Thanks so much. Thank you so much for coming on. I really appreciate it. And I hope, will I see you in Denver next week?
Yes, I'll see you in Denver.
Fantastic. Very excited.
Thank
All
you.
right. Thank you, Michelle. And for everybody else out there, until next time. Thanks so much for listening to the Psychedelic Medicine Podcast. If you enjoyed what you heard, please leave a rating or review as it helps others find the show. And if you'd like to learn more, you can find the show notes at plantmedicine.org/podcast, and there's information for clinicians at psychedelicmedicineassociation.org. Our incredible music was by the one and only Porangi. We'll see you next time.